Hi, welcome to my presentation. My name is Christopher Carpenter, and I'll be presenting on the outcomes I collected within the acute care setting. So this study took place within a hospital within the Veterans Health Administration. In this specific setting, there were 10 clinicians, 9 of which were PTs, and 1 was a physical therapist assistant. Each clinician had a caseload of about 6 to 10 patients, and the clinicians treated a wide variety of primary diagnoses. So basically, the clinicians did not treat based off of a specialty. They instead divided up patients that were kind of based off their current caseload. So they split it up evenly and really worked as a team to accomplish the whole caseload. Treatment decisions were based off clinician experience, clinical practice guidelines, and physician precautions. A typical treatment session consisted of the patient getting out of bed or out of their chair and then performing ambulation. Based on the patient's fatigue level, some sort of functional strengthening was performed after walking, such as about like sit to stands or knee extensions or such. During every treatment session, an outcome measure was collected, and there was not really an existing system in place for collecting outcomes, so I had the freedom to choose outcomes as I saw fit. I chose to collect the 6 clicks on every patient. This was just based off the ease of deliverance and literature defending the use of this measure when making discharge recommendations. Moving to the patient population, there were 15 patients in the study, all 15 of which were males between the ages of 60 to 95, which makes sense when you think that 98% of the hospital population was male and between the age of 60 to 95. Like I mentioned earlier, because of the way the clinicians divided up the caseload, each PT treated a wide variety of primary diagnoses. The largest category my patient population fell into was orthopedic injuries. So 7 out of 15 of the patients that are being treated had an orthopedic surgery of some sort. This included total hip replacements, total knee replacements, and internal fixations. The average length of stay for most patients was about 5 to 6 days. And for my population, I actually had a few outliers, which, as you can see in the poster, raised my average length of stay to about 14 days. And these 3 outliers all had stays greater than 28 days. So moving to the outcomes, I use a minimal detectable change that was found to be 4.5 points. And this was found to for a population within the general acute care setting. So this just means that the patient must increase their score by 5 points on the 6-click scores to denote a meaningful change. So for the sake of the study, measurements were collected at 3 different time points. If patients had more than 3 treatment sessions, I took the measurements for the first visit, last visit, and the visit that landed directly in the middle of those. For example, if a patient had 10 treatment sessions, scores for the study were used at the 1st, 5th, and 10th session. At the second visit, 6 out of 15 patients had demonstrated meaningful change, and that number became 8 out of 15 at the 3rd visit. As you can see by the graph at the bottom of the poster, the average score at each timestamp was higher in my population than in the class averages. On top of that, my average rate of change, or the average slope to the blue line, is 2.3, whereas the average change for the rate of change for the class was 1.1 points per visit. A large reasoning for this is the fact that about half of my patients were being treated right after an orthopedic surgery. And therefore, when the anesthesia wore off, the patient usually saw a large improvement in functioning. 6 out of 8 who met the MDC had an orthopedic surgery. And we did have one outlier who got significantly worse. And this was due to a progression in his disease process, causing a large decrease in functional ability. So in reflection, getting into the repetition of collecting an outcome measure on every patient and using that outcome measure to make treatment decisions opened my eyes to the importance of collecting outcomes. Before, during my outpatient orthopedic rotations, I didn't really have a system in place. And this didn't allow me to physically administer the outcomes. The front desk staff actually administered the outcome. And so rarely did my CIs actually use those outcomes to make treatment decisions. So therefore, being given the freedom to choose which outcome I'd like to administer, collecting the data, and using it to make discharge recommendations helped me to see the importance of this process. Now, this was my first experience in the acute care setting. So as you can imagine, there was some rocky start. I would really focus on making sure that lines and tubes were out of the way and not really how well the patient was functioning. So therefore, I kind of forgot how to score early in the earlier weeks of my rotation. But as I got a habit and made it repetition, this became much more easier. So So what recommendations I'd have for the future is just become more organized when scoring the patient and paying closer attention to their level of functioning as you become more organized. I hope you enjoyed this presentation, and let me know if you have any questions below.